Okay, good evening, everybody. Welcome back to another webinar, and this time is our second session in a series of many with Beacon Hospital, and one CPD point will be awarded. And we have here Dr. Tan, who is a gynecologist, a colleague of mine in Beacon, and he also has his own fertility center in Subang Jaya, if I'm not mistaken, right, Dr. Tan?
Yeah,
okay. So Chiu, without further ado, we invite him to give us more insight into common gynecological diseases.
Thank you everyone for participating in this webinar. Let us start the webinar without further delay. I tried to cover as much as possible for the common gynecological disease. I'm a Dr. Tan. I'm a chief obstetrician and gynecologist, also minimus invasive surgeon, specialized in fertility. Our outline is actually anatomy, reproductive function, and physiology. How we use the ovulation induction agent? How do we detect ectopic pregnancy? Polycystic ovarian disease, Bartholin cyst, labia abscess management, menorrhagia, uterine fibroid, adenomyosis, polyps, ovarian cysts, and also cervicitis and PID. Also, how to manage the cervical intraepithelial lesion, which is abnormal. All right, if we have time, then we talk about vaginal discharge. So this is our female reproductive organ. You have the external major labia minora and also majora. Then this is the vagina opening. So this inside this vagina opening, about 8 to 10 cm, you have the cervix. The whole organ is a uterus. There's 2 fallopian tubes and 2 ovaries. The function of the vagina is for reproductive function, and also part of the birth canal. The uterus is to house the fetus and also to nourish the fetus. The fallopian tube is a place where the sperms fertilize the eggs, which also facilitate the fertilization. Ovaries contain of germ cell, which actually control our female hormone, estrogen and progesterone, and also to produce eggs for to pass the genetic material to the next generation. So at this, there's a Bartholin gland at the 5 o'clock and 7 o'clock near the posterior fossa. There's a vaginal opening, urethra, and clitoris. There's a mount pubis here. All right, this is a sagittal view of the female internal organ. You have the skin, tummy fat, intestine, bladder, uterus, rectum, spine, and also your back. So this is how it looks like during the laparoscopic surgery. This is a brown ligament, fallopian tubes, ovaries. All right, this is a side way how the cervix look like in real life. When you put in a speculum, you should visualize the cervix. So hypothalamic pituitary axis, actually most of the endocrine function is controlled by the brain, although pituitary is the master of gland. All right, so this hypothalamus will secrete this gonadotropin releasing hormone, stimulate the pituitary to release the gonadotropin such as luteinizing hormone and follicle stimulating hormone, which in terms the ovary will produce progesterone and estrogens. So during the first day of the period, towards the next cycle, first day of the period, the whole period is termed menstrual cycle. It is divided in 3 phases: follicular phase, ovulation, and post-ovulatory phase or luteal phase. So during the first half of the follicular phase is a menstrual phase also. So when this egg, during first day of the period, the ovary will collect about 20 to 30 eggs, but however, there's only 1 egg will grow to a mature size, then ovulation will take place. Like the chicken eggs released from the ovary and follicles. If the sexual intercourse happens, the sperm will swim from the vagina into the uterus, into the fallopian tube, where the eggs is fertilized. Over the right lower end, the ultrasound picture, this is the mature follicle, looks like about 18 to 20 mm. So if the ovulation take place and there's a sexual intercourse, patient will likely to get pregnant. Okay, if fertilized in the fallopian tube, take about 5 days to reach the uterus. If the fertilized egg stuck in the fallopian tube, then we call it ectopic pregnancy. Then it takes about 7 days for the implantation to occur. So this is after count from the first day of the period, the average pregnancy about 40 weeks. If you count from ovulation, average of pregnancy is 38 weeks. So if the pregnancy doesn't occur, the lining of the endometrium will shed, then the bleeding start to occur and the next cycle of the menstrual cycle begin. So this is how the ultrasound of the uterus look like in the sagittal view. This is the bladder, the uterus. At the center there, the uterus is a bit big, which appear like adenomyosis. And this is the uterus. The white strip here is the endometrium. If you got ultrasound, a lot of GP already have ultrasound. So if you have ultrasound, you can scan the kidney, you can scan the liver. At the same time, you can scan the reproductive female organ also. So this is a vagina scan. If you have a vagina scan, it will be an additional good point for GP to manage the female gynecological cases. This is the uterus. The lining here is very thin. That means at the beginning phase of the menstrual cycle, when the uterus have 3 strips inside the cavity, it indicates the patient is actually near ovulation. When after ovulation, the lining inside become luteinized, become white in color. All right. So this is at the center here. This is the ovary. Inside this ovary, there's a lot of pots hole, black pots hole here. This indicate the follicle inside the ovary. And over the right side, there's a big follicle there, indicate maturity of the eggs. All right, you see on the center right side, there's a lot of there are a lot of eggs, about 10 of them. This is the IVF follicle. I mean, the stimulation we've done with gonadotropin. So how do you calculate a fertile period? First of all, your period must be regular. You take a 3-month average. The first day, the first day between the 2 menstrual cycle is your menstrual cycle length. So you minus 14 days from your first day of your menstrual cycle, then you will get your your ovulation date. So normally it's retrospective. However, you can take the LH test kit, urine LH test kit to increase the sensitivity. Best time to have sex, 14 days. If you calculate 3-month average, 14 days from the first day of your period, this is your
ovulation. Any time is a good time.
So you can do a LH test kit. If you see 2 light, 1 faint, 1 light, then you know that the hormone is start to rise. When there's a 2 dark line, that means ovulation will occur in the next 24 to 36 hours. So you can, the GP side or the general practitioner should also can take some hormones or manage some fertility cases also. For FSH, normally it's less than 10. LH also less than 10. Anything more than 10, it means the ovary has not many eggs inside because there's a reduce in negative feedback. All right. So for progesterone, if the progesterone is more than 25 nanomicromole per liter, that means ovulation is normally occur. Normally 7 days after the ovulation, you test for the progesterone. FSH always normally test the day 2, day 3 period where the hormone is low. High means the ovary, the pool has actually been reduced. So normally the fertilization happen in the fallopian tube. You can also do HSG to check the tubal patency. You can the general practitioner should do that also. All right, you want to know whether there's a polyp, submucosal fibroid, or there's a structural defect such as didelphi, bicornate uterus, and etc. So this is how the hysterosalpingogram looks like. All right, you can see that this is the, the uterus cavity like a triangle, which is normal. There's a small line here, which is the fallopian tube, which is not swollen. All right, if it's blocked, then you won't see the tracings. If it's blocked, then we become hydrosalpinx. All right, if the cavity have a hypoechoic lesion inside, most likely it's either a polyp or submucosal fibroid. So this is how the sperm looks like. Okay. Normally the testes have 2 functions, to produce testosterone and also to produce sperm. All right. Normally semen analysis is done under a microscope. Total concentration about 50 millions in the latest reference. All right. Total sperm is 39 million, progressive is 32%, mortality about 40%. Normally the pH is alkaline, the morphology about 4%. Oligospermia means less than 50 million, within 10 to 15 million. Moderate oligospermia, 5 to 10 million. Severe oligospermia means less than 5 million. That means, first of all, you need to calculate the count, whether the sperm is good in motility, all right, whether the shape and size of the sperm is actually normal. So, however, male has no effective treatment for male infertility. Generally, avoid wearing tight jeans, avoid sauna, processed food, fast food, should quit smoking and alcohol, and not quit your job because it's COVID, because the scrotum and the eggs are too near the the stove. Sometimes it can be I mean the structure can be can be affected. It can take some supplements, selenium. And as long as there's a sperm, the treatment for male infertility is straightforward. So indication for ovulation induction, normally end ovulation, for example, polycystic ovary, ladies with irregular menses, unexplained infertility. What is the prerequisite for giving ovulation induction agent? The fallopian tube must be normal. The sperm analysis, male factors, which means the sperm is about 10 to 15 million. So ovulation induction normally take from day 3 until day 7 for 5 days. You take the clomid from 50 milligram daily to 150 milligram daily, Femara 2.5 milligram to 7.5 milligram daily. So you ask the patient to come back for scan. You can do a tummy scan. You can do a vagina scan. If you see a growing follicle, then you can ask them to time the coitus, or you can give HSG, pregnio, and also the Humoc or Hucoc to induce the ovulation. Over the right side, the clomid citrate, the mechanism of action is it is actually selective estrogen modulator, and for the Femara is actually aromatase inhibitor, inhibit conversion from androgen to estrogen. So there's a loss of negative feedback. So the pituitary will produce more gonadotropin to stimulate the ovary to produce more eggs. So other tests you can do at the GP practice is you can do anti-Mullerian hormone. This anti-Mullerian hormone is actually secreted by the young follicles inside the ovary. So as you know that when the ladies age, the follicle inside the ovary become depleted. So the MH will start dropping, all right, every year. So we want to know whether these ladies are in the normal range of anti-Mullerian hormone. So other than that, you can do a pap smear. You should do a mammogram because fertility should not be the main treatment on it. You should look at the female as a general well-being. Can do also infective screening, especially they require IUI or IVF. So for ectopic pregnancy, normally there's a triad period of amenorrhea, abdominal pain, and PV bleeding. On and off, the ladies will come with a positive urine pregnancy test. The last menstrual period may not be reliable. Sometimes they cannot remember, sometimes they didn't jot down, sometimes the period is irregular. So most of the time it's not reliable, all right? So majority have no obvious risk factor, history of ectopic, pelvic surgery, pelvic inflammatory disease, endometriosis, took emergency contraception, smoking, and etc. You must have a high suspicious of index of suspicion. You must, unless you see a gestational shape with a fetal echo and fetal heart activity, it is ectopic until proven otherwise. So it's necessary that you may need to repeat the ultrasound. If you see a beta HCG, 1005 to 2000, you must see something. If you see the uterus is empty, urine pregnancy test is positive, HCG is more than 1005, then it's ectopic. All right. Sometimes you can see a pseudosacs inside the uterus. You can see a free fluid, annexa mass. You can sometimes even see the baby, the gestational sacs outside the uterus with the baby heartbeat. So you know that it's an ectopic pregnancy. This is to show you the uterus here. The endometrium lining is thickened because of the hormone, pregnancy hormone. However, you cannot see a sac. Over the right lower side, you can see a pseudosac. It's not a sac, it's just a fluid collection. All right. On the right upper image, you can see a gestational sac with a fetal echo inside. This is what you want to see. Most important thing is look for whether the uterus is whether empty, there's a sac or not sac, and fluid collection. If there is a fluid collection, the uterus is empty, then it's the time to refer. Otherwise, you think the patient is stable, then you can just repeat another HCG. Maybe it's just a miscarriage. So for polycystic ovarian syndrome, Normally, they have ladies with problem with weight gain, irregular menses, problem trying to get pregnant, excessive androgen, they got acne, they got hirsutism. Sometimes they got a hair over the chest, all right, over the limbs. So excessive androgen. Normally, it's interplay between insulin resistant, hyperinsulinemia, hyperandrogen, and chronic anovulation. According to Rotterdam criteria, you need 2 out of 3 to diagnose polycystic ovarian syndrome, oligo or ovulation or anovulation, hyperandrogenism, either clinical or biological. Clinical, you look for hirsutism and acne, and biological, you look for androgen-free index and testosterone level. So polycystic ovary can be visualized under vaginal ultrasound. You have 12 or more follicle, which each of the follicle is between 2 to 9 mm, and the ovarian volume about 10. So 1 in 10 ladies will actually have polycystic ovarian syndrome. And sometimes they may have, sometimes they are overweight, they may have high blood pressure and diabetes. So if the ladies are put on weight, sometimes the period become more irregular. If they reduce the weight, then the period become, they have done a study and claim that the period become more regular. All right, this is the ultrasound for the polycystic ovary. There's a lot of small pots hole here. If it's more than 12, that means this lady is likely to have polycystic ovarian syndrome. If you look at this animation here in the center, you can see that there's a lot of small follicle inside the ovary, which is not mature. Okay. On the other hand, if it's mature, if it's a normal ovary, there should be less than 10 follicle there, and all the follicle are in a different stage of maturity. So for polycystic ovarian syndrome, previously there's a criteria. The LH is about 2 times the FSH, but this is no longer a criteria. LH and FSH is normally high in polycystic ovarian syndrome. And if you do ultrasound, there are a lot of small follicles inside the ovary. All right. On the other hand, if it's normal, then you can see the hormones, gonadotropin and estrogen and progesterone, they are actually fluctuating most of the day. So management-wise, good sleep, diet, low carbs diet, control the diet intake, more fruits, more vegetable, less simple sugar, avoid processed food and fast food, control the weight, exercise, because there's an increased insulin resistance. So you want to increase the insulin sensitivity. So other than that, avoid smoking, avoid alcohol. So treatment-wise for polycystic ovary, weight loss, exercise, diet, you must at least have 3 to 4 times period per year in order to reduce your risk of endometrial cancer. If the endometrium become thick and thicker, there's a risk that it undergo transformation and become cancerous and even develop polyps. So for those who are not keen for pregnant, you can actually induce the period with the Povera, COCP, no aldosterone. You also can give COCP to reduce the testosterone effect for the facial hair, exotism, acne. You can start Diane, Yas, Yasmin, and etc. All right, for hirsutism wise, you can do shaving, waxing, electrolysis, laser, spironolactone, even bleaching. Fertility, if they are keen for fertility treatment, you can start metformin. You can give some clomiphene or Femara that I have spoken just now, or if this failed, you can refer to us for further fertility treatment. Also, prevention is also important for diabetes, high blood pressure, and also cardiovascular complication. Rarely they require laparoscopic ovarian drilling and also a bariatric surgery, that means bypass the stomach. So Bartholin gland normally located about 5 and 7 o'clock of the east side of the vaginal opening, secrete fluid that help to lubricate the vagina when especially during sexual arousal. Sometimes the opening can actually become obstructed due to hygiene purpose, sexual transmitted disease, or ascending infection. Cause the fluid to accumulate back up to the gland and cause swelling. Normally it's painless swelling called Bartholin cyst. So this is where the Bartholin located. So if at 5 o'clock, 7 o'clock, so if you have this portion, highly suspect of Bartholin gland. So this is how the muscularization is done. However, I don't encourage you to keep the Bartholin cyst or Bartholin abscess, because there's a higher risk of recurrence if the surgery is done in a GP setting. So you just open up the Bartholin. So you do a marsupialization, create a pockets at the gland, so the drainage can be come out directly from the Bartholin. So Bartholin abscess, if the fluid in the cyst become infected, there's a develop into a collection of pus surrounded by the inflamed tissue. So patient may complain of fever, pain during walking, during intercourse, painful lump near the vaginal opening. So treatment, broad spectrum antibiotic. If it's not infected, if it's very small, so you can try conservative. All right. Bacteria, anaerobes and aerobics bacteria, you can give some analgesic after let's say you have done the surgery, the simple surgery at your clinic, you should do a wound care and dressing. All right. If you think that you cannot manage, you should do a referral. So labia abscess is where the hair punctum follicles become obstructed. This picture here is a baby that there's an infrequent change of the diapers, the follicle become blocked, so that there's a blockage in the sebaceous gland and also the pores due to hygiene or ingrowth of hair, opportunistic infection, etc., leading to inflammation, infection, then spread to the nearby structure and subcutaneous tissue. Treatment-wise, painkiller, NSAID, broad-spectrum antibiotic, antiseptic cream, and for labia abscess, this can be done in a GP setting. It's simple, recurrence rate is actually quite low compared to the Bartholin gland marsupialization. So refer if patient is septic or the abscess extended into mum pubis, or the patient has a lot of comorbid age, diabetes, high blood pressure. This is a case, or heart disease. This is a case that you want to make a referral. So for cause of uterine bleeding, abnormal uterine bleeding, basically you use the palm coin to assess the cause. It is either can be a structural cause or non-structural cause. Structural cause can be the polyp inside the uterine cavity, adenomyosis, which I'm going to explain to you later, fibroid, even malignancy need to be considered. So especially they got abnormal uterine bleeding at 40 years old and above, this is a case you want to investigate, or highly suspicious of endometrial cancer or even cervical cancer. Or can be due to the bleeding disorder, undiagnosed bleeding disorder, or even cirrhosis, or patient is on anticoagulant, etc. So can be due to ovulation dysfunction. In adolescent, the hypopituitary ovarian axis is not matured, so sometimes they can have an abnormal uterine bleeding or menorrhagia. Perimenopause, because the ovary have no longer have many eggs inside, so the ovulation can be dysfunction. Polycystic ovarian syndrome, hypothyroid, anorexia at least. So other than that, dysfunction uterine bleeding is a exclusion. All right, you must exclude other causes in order for you to diagnose dysfunction uterine bleeding. Other than that, is iatrogenic hormonal contraception use, HRT, post-surgery. This also can lead to abnormal uterine bleeding. Other than that, is the pelvic inflammatory disease, endometritis, cervicitis, and etc. So how do you investigate ultrasound? So ultrasound is very important if you want to manage gynecological disease in a GP setting. Right, you can do a pap smear to rule out the cervical cancer. Ultrasound can rule out fibroid, endometrial polyps, even ovarian cysts. So if you're 40 years old, above 40 years old, I encourage you to do endometrial sampling or PPR sampling at your office. All right, if the PPR sampling is normal, you can rule out endometrial cancer. Then this patient, you can wait. All right, you can refer this patient later and see how is the response. If the patient responds well, you can keep it at your clinic. If it doesn't respond well, then you should refer the case. This hysteroscopy, endometrial ablation, myomectomy, and hysterectomy, this is a specialized procedure. If the patient requires this procedure, you may need to do a referral. Dysfunction uterine bleeding is a diagnosis of exclusion. So for menorrhagia or abnormal uterine bleeding, treat the underlying cause. Discuss with the patient about your treatment plan, whether are they ready to accept what you offer. All right, over the right side here, lower right side here, this is the PPAP. There's an insert where you will withdraw, then it will create a vacuum. So you basically, you do it like a DNC. So you pass it inside the cervical os and cervical canal into a uterus. You just take some sample. All right, maybe in a 3 to 5 attempt to take some tissue and send to the histopathological examination. So treatment-wise for menorrhagia and normal uterine bleeding, iron supplement, tranexamic acid, antifibrotic to stop the bleeding. Mefenamic acid also is good as a prostaglandin. You also can reduce the pain, reduce the bleeding. Actually, the first line is actually Mirena. If you know how to put in the IUCD inside the uterus, then it will be good. If you have ultrasound, we can even do it under ultrasound guidance. All right. Other than that, you can start COCP, a simple COCP, Diane, Yasmin, Mercilon, Lloyd, etc. Sometimes some GP can start norethistron or Povera. If the patient does not respond to your treatment, please refer. All right. Avoid the gonadotropin releasing hormone antagonist or agonist. So endometrial polyps is actually excessive growth of your endometrial tissue. Uterine polyps are the growth that attach to the inner wall of the uterus, overgrowth of the cell lining of the uterus, leading to formation of polyps. Most of the time, the polyp is not cancerous. However, some of them, minority of them, will turn into cancer. So sign and symptom of uterine polyp, irregular menstruation, intermenstrual bleed. The menstruation is actually slightly prolonged and heavy, and can be excessive menstruation, vaginal bleeding after menopause. All right, most of the time it's asymptomatic. All right, sometimes they do cause infertility because these polyps secrete some toxin, create an environment which is not suitable for implantation. So when you do ultrasound, then you can see that there's a mixed echogenicity inside the uterine cavity, indicate it may actually is a submucosal fibroid or polyp. You can even do a saline sonography if you want. Put some fluid inside the uterine cavity. This one will help you to delineate the structure either of polyps or also submucosal fibroid, whether the mass arises inside the cavity or from the muscle wall. So this is how the polyp looks like. Normally, patient require hysteroscopy and polypectomy. So we can resect it, also can grind it. We also do some curating. So risk factor are perimenopause, but age of 40 to 50, patient having high blood pressure, obese, patient on tamoxifen due to breast cancer, therapy for breast cancer, polycystic ovarian syndrome. Problem with endometrial polyp, dysmenorrhea, menorrhagia, intermenstrual bleed, miscarriage, infertility, and also bleeding after menopause. The risk of cancer actually is very low. Uterine fibroid is actually benign disease. It is an overgrown or a muscle cell inside the uterine muscle. All right. So normally it happens in the reproductive age group. Majority is asymptomatic. Risk factor: obesity, family history of fibroid, nulliparous, early menarche, late menopause, also exogenous, endogenous hormone. So if you have fibroid, so there's 1 in 2,000 is become cancer. If the patient is symptomatic, 1 in 400 is a cancer. Majority of the time, if it's more than 5 cm, likelihood of cancer is higher. If it's less than 5 cm, the likelihood of cancer is lower. So uterine fibroid, the symptoms depend on the number of the fibroid, the size of the fibroid, the type and location of the fibroid. If you look at the right upper image, so you can see a submucosa which is inside the uterine cavity. Then this one will create a lot of heavy bleeding because the uterus not able to contract. There's a mass inside and the polyp can bleed on and off. All right, if it's outside the uterus, it's pedunculated or subserosal fibroid. This one, like most likely, will not cause problem unless it get twisted or infected. All right, if it's near the muscle wall, sometimes it does cause a bit of miscarriage, heavy periods, abnormal line, and so on. Okay, so majority are actually asymptomatic. Majority just need to treat conservatively. If it's around 3 cm, you can keep it inside the clinics. But symptomatic are menorrhagia, miscarriage, pressure symptom when the fibroid have grown so big, it compresses on the bladder and also the rectum. Or if the fibroid become painful or very fast growing, then you have to suspect cancer. So investigation, full blood count if the patient having a menorrhagia, do an ultrasound to assess the size of the fibroid. HSG, if the patient is having an infertility or menorrhagia, you suspect submucosal fibroid or polyp. All right, rarely patient require a CT scan or hysteroscopy. Normally, ultrasound should be sufficient. So medication, painkiller, uterine has been withdrawn from the market because it caused liver failure. Other than that, you can start tranexamic acid, some hormone therapy like COCP. Zoladex, Lucrine, diphtheridine, these are peri-operative medication to reduce the size of the fibroid before the operation, from laparotomy to laparoscopy, from a bigger wound, to a smaller wound. So it helps us manage to shrink the fibroid. So normally the fibroid is done, if it's a completed family, then we can do a hysterectomy. If the family is not completed, then we normally conserve the uterus. Either can be a Phenestyle or either can be midline, depends how big is the fibroid, where is the fibroid. Sorry, the thing start. Okay, other than that, we also can remove the fibroid through a laparoscopic surgery. Rather than cutting up to down, side to side, we actually can remove the fibroid through a laparoscopic keyhole surgery. We can try to take out the fibroid through laparoscopy. So we can actually take out the fibroid, put inside the bag, morcellate it, and take out from the laparoscopic keyhole wound. All right, we also can also do a hysterectomy to take out the fibroid from the vagina. All right, rather than the traditional surgery. So other than that, you also can do a uterine artery embolization. The indication are heavy menstrual bleeding, dysmenorrhea associated with the fibroid, premenopausal. They have no desire to have pregnancy because you embolize the uterine artery. Then if patient pregnant, there will be a fetal growth restriction because there's not enough blood flow to the uterus and to the baby. Not suitable. If the patient not suitable for surgery, then you can try. We can go for the uterine artery embolization. So other than that, increased evidence of MRI guided high intensity focused ultrasound. These are good for single fibroid, small fibroids, all right, not multiple fibroid and big fibroids. So they focus the ultrasound, then create a heat to create a central necrosis. So the fibroid can shrink to 30 to 40%, up to 50%. So adenomyosis actually occur when the tissue on the normal lining of the uterus, called endometrial tissue, ingrow into the muscle wall. So during each menstrual cycle, the displaced tissue begin to bleed, inflame, and thicken inside the uterine muscle, result in enlarged uterus, painful period, heavy period, prolonged period, dyspareunia, which is pain during sexual intercourse, and infertility. Why it causes infertility? Because the uterus no longer receptive to the implantation. Risk factor adenomyosis is in mid-40s, previous childbirth, especially cesarean section, history of miscarriage require DNC. There's an endometritis or history of infection. This will actually interrupt with the endometrial myometrial junction, create a risk factor for adenomyosis. So you can do ultrasound. You can see that the anterior wall and the posterior wall. Normally, the posterior wall is most of the time affected. You can see the anterior wall actually is smaller compared to the posterior wall. If you look at the center, this is the endometrial strip, which is hyperechoic in nature. When during the ultrasound, you can see the hyperechoic lesion is actually inside the uterine cavity, just like a sandstorm appearance or snowstorm appearance. All right, okay. Then you can see a white and a black background at the posterior wall. So this is the MRI of the adenomyosis. You can see that the wall here is actually thicker than compared to this wall here. This is a specimens of the adenomyosis. The uterus is enlarged. So treatment anti-inflammatory drugs 1 to 2 days before the period begin, reduce the menstrual pain and also the menstrual flow. Antifibrolytics such as tranexamic acid, hormone therapy. You can use COCP to reduce the bleeding and also the pain. Progesterone only contraception is not recommended, because if the period is irregular, you put a patient on progesterone, the period becomes more irregular. All right. If you want to know whether the hysterectomy is useful, then you can try a GnRH if the hysterectomy is beneficial. If the pain is severe and no other treatment works, then this is the time for hysterectomy. So limited evidence of endometrial ablation, high intensity focused ultrasound. So by doing this, the endometrium lining get destroyed by heat. Okay. Now we talk about ovarian cysts. Ovarian cysts, this ovarian follicle, they are actually germ cells. They have potential to become a baby or any cell. So if there's under a situation where they get stimulated, it can form a cyst, complex cyst, endometrioma, dermoid cyst, mucinous cyst, ovarian tumor, and even cancer. So the risk factor are nulliparous, delayed childbirth and pregnancy, fewer children, small family, history of smoking, alcohol, pollution. However, birth control pill has some protective effect. So you want to see whether the tummy is distended. Most of the time it's asymptomatic. It's an incidental finding during the physical examination. There's a period pain, irregular menses, pressure symptom to the bowel and also the bladder. So when the mass becomes so big, it becomes risk of twisted, perforated, infected. All right. So this is the ultrasound finding or the simple cyst. If this simple cyst is 3 to 4 cm, below 3 to 4 cm, you can keep the patient. You can give patient a try of the COCP, see whether this suppression can actually resolve the ovarian cyst or not. All right. If it's bigger than that, then you need a referral for the operation. So complex ovarian cysts such as endometrioma, this is due to the retrograde menstruation, hormonal stimulation, metaplasia, immune dysfunction, apoptosis of suppression, or genetic. That means there's a backflow of the menstrual blood with the endometrial cell back into the peritoneum. And this endometrial cell implant on the uterus, implant on the bowel, implant on the ovary. When it invade into the ovary, when the menstruation starts, then this ovary start to bleed, create a chocolate cyst or endometrioma. Normally, it causes pain, menorrhagia, and infertility. So dermoid cyst, when you do a scan, you can see a mixed echogenicity. Then you can have solid and cystic mass. All right, majority of them, 90%, is actually benign. So investigation for ovarian cyst, ovarian tumor is actually you do a tumor marker. If it's a mildly raised, you better refer. All right. Other than if it's normal, you can keep the patient. Ultrasound, simple cyst you can manage by yourself. If it's complex, most of the time it's benign. However, sometimes it's very difficult to differentiate from benign from cancer. So for this case, it's better to refer. All right. You also can order a CT scan or can take a tumor marker if you plan to refer this patient. So treatment-wise for ovarian cyst, ovarian tumor, ovarian cancer, most of the time surgery. Cyst, we only remove the cyst if it's more than 3 cm if the patient is symptomatic. All right, less than 4 cm, normally we will not, 3 to 4 cm, normally we will not operate. Ovarian tumor, remove the womb, fallopian tubes, and ovary, sometimes omentum. If it's a cancer, or hysterectomy, also remove the womb, fallopian tube, ovary, omentum, lymph node. Sometimes patient require chemotherapy after that. So if it's not cancerous, then we can do a laparoscopic surgery where this capsule is opened up and the cyst is removed. Then we can close back the space. Ovarian cancer require operation. Normally THBSO, total abdominal hysterectomy, bilateral sublingual oophorectomy. Then we can do some lymph node excision. So this is my patient where we operated on for ovarian, bilateral ovarian cancer. So other topics are cervicitis, PID, cervical intraepithelial lesion, cervical cancer, vaginitis. I'm finishing soon. Infection, cervicitis means there's an infection on the cervix, most often bacterial and viral in origin. But cervicitis can result from common sexual transmitted infection such as gonorrhea, chlamydia, trichomoniasis, HPV, even genital herpes. Normal and healthy bacteria in the vagina can be overwhelmed by the unhealthy and harmful bacteria, for example, bacterial vaginosis. Other causes of inflammation or cervicitis can be due to allergy, spermicide, excessive dosing, allergy to condom, and etc. Irritation from the tampon, also soap. Sign, abnormal discharge, vaginal bleeding, intercoitus bleeding or intermenstrual bleeding, postmenopausal bleeding, pain during sex, difficulty and painful urination. All right. Abdominal and pelvic pain, sometimes fever, you must suspect pelvic inflammatory disease. Here, there's a discharge from the cervix. So risk factor, multiple sex partner, early exposures, debut during teenage age, unprotected intercourse, smoking, alcohol, drugs, diabetes, or immunocompromised. How do we prevent PID? How do we prevent cervicitis? Early treatment, all right, early recognition, sexual education, good health care, and higher education actually can delay a sexual exposure, limit the sexual partner, condom, treat the partner, child protection and statutory rape law, women shelter, engage, empower women, and also law enforcement on the drug usage. Screening and prompt treatment, immunize for the cervical HPV to prevent cervical cancer. So complication, endometritis, salpingitis, oophorectis, tubal ovarian abscess, and pelvic inflammatory disease. These are due to the extending infection from the lower genital tract, from the chlamydia, gonorrhea, mycoplasma. Most of the time it's polymicrobial. That means there's more than 2 bacteria of causes. So treatment for PID, most of the time patient will present with abdominal pain, fever, vaginal discharge, and most of the time they are sexually active. Normally they are unwell. There's a tenderness in the lower abdomen and nexa. If you do a vaginal examination, cervical motion can be positive, vaginal discharge, cervix may be inflamed. There's an increase in total white, ESR, C-reactive protein. You can take a swab, can do a urine PCR, and you should do ultrasound. Look for mixed echogenic mass, that means tubal ovarian abscess, pyocellular, and also pelvic collection. This is the fluid inside the endometrial cavity. At the second here, there's the fallopian tube become hydrosulfing, where there's a fluid collection there. And the lower one image, that means there's a tubal ovarian abscess here. So outpatient, you can treat them as outpatient. We assess them after 48 hours. Include symptomatic treatment, antipyretic, painkiller, anti-inflammatory, screen for STD, treat their partner also. For severe and tubal ovarian abscess, they need a referral. If they are, especially when they are septic, they are unwell and they doesn't respond to your treatment. Refer if there's a free fluid and collection. Look hard for tubal ovarian abscess. If there's no tubal ovarian abscess, you can treat them for PID, no problem. Or sometimes we require intravenous antibiotic. Conservative most of the time, rarely require surgical drainage and excisions of the tubal ovarian abscess. So antibiotic-wise, broad spectrum, because it's also multimicrobial, and need to cover aerobic and anaerobic. Most of the time, you can give cetrizone 500 mg stat. You can give doxy and flagyl for 14 days with azithromycin 1 gram stat. Some GP can give gentamicin. If you want, you can add gentamicin. Or you may want to stop the cetrizone once the patient become better. All right. Other choice antibiotic, ampicillin sulbactam 6 hourly, but this is more hospital care. Clindamycin 900 AV TDS, gentamicin, but this is more hospital regime. Other than that, do an infective screening, HIV, hepatitis, syphilis, gonorrhea, chlamydia. Also, you can do a HPV warts investigation. Other than that, herpes simplex like trichomoniasis. So for cervical cancer, same risk as the cervicitis. Cervical cancer happens because of the persistent human papilloma virus infection. And this infection causes the cervical transformation zone, the cell there to transform because they are active. So once they're infected, the infection persists, then they cause cervical intraepithelial neoplasia or lesion. These are precancerous lesions. All right, if they are left alone, about 5 to 10 years time, they become cancer. The diagram here shows that this is a normal cervix. There's a CIN1, CIN2, and CIN3. Most of the CIN1 and 2, they can revert to normal. It's unlikely that CIN3 become revert to normal. All right, if you leave it alone, the patient may have cancer later on. Cervical cancer is actually preventable. No women should die from cervical cancer. Actually, most of the time, cervical cancer peak at 40 years old. Incidence is 11 to 30 in 100,000. A lot of Chinese, more prevalent in Chinese compared to Malay and also Indian because of the sexual practice, and they have more sexual partner. All right, majority of our ladies here in Malaysia, 2/3 is actually presented at a late stage 2 and above. Most of the time, when you compare to the overseas, European, UK, and also US, they present earlier than us to the doctors. Right? It associates with morbidity and mortality. So the sign and symptom of the cervical cancer is abnormal vaginal bleeding, such as bleeding after sex or intermenstrual bleeding, postcoital bleeding, postmenopausal bleeding, abnormal discharge and pain during sex, difficulty and painful urination, pelvic abdominal pain. When they have pelvic abdominal pain, that means they have dysuria. That means the cancer must have spread outside the cervix. So this is to show you that this is the virus that actually attack the transformation zone. Then in the long run, then this CIN1 or 2 and 3 become cancer. That's a mess here. When the time they become necrotic, they will have a postcoital bleed, intermenstrual bleed, and also abnormal discharge. Then after they spread to the surrounding bladder, rectum, and also nearby lymph nodes and metastasize to liver. So HPV has been implicated. High risk, they cause most likely to cause cancer. Low risk, it is more towards warts. However, some low risk HPV can be associated with cervical cancer. 99.7% of the cervical squamous cell cancer is associated with HPV infection. On the other hand, adenocarcinoma or cervix are also related to HPV, but the correlation is less pronounced and is also age dependent. In women younger than 40 years old, HPV was present in 89% of the adenocarcinoma, where in women more than 60 years old and older, HPV observed is only 43%. So HPV is associated with cervical cancer, all right? So we can also give vaccine. This is the first generations of Gardasil, second generation of Gardasil. Cervarix only covers 16 or 18. This is not recommended. Other than that, this is there are 100 subtypes of the HPV. All right, but only a number of them, about 20 of them, cause cervical cancer and warts. All right, but other than that, it causes cervical cancer, anal cancer, vulva cancer, and throat cancer. If there is the anogenital wart, you can give Aldara, or you can give podopilotoxin, but I cannot find polyphlotodiazine most of the time. I'm so sorry. Okay. Or you can do laser to remove the warts. Also can do excise them. All right. Okay, normally if you don't have the, let's say GP don't do pap smear, right? If you think of doing a pap smear, this is the way you should do a pap smear. First of all, you tell the patient, you get them ready, you show them this, maybe you can show them this light, then you actually need to part the labia. So when you insert the speculum, you will not cause pain. All right. So normally you insert directly into the vagina, then you can visualize the cervix. And this is the cytobrush. Then actually, this is the side view of the uterus and also the cervix. All right. Normally, you need to take the endocervical cell also. All right, in order to have the good sample. All right. Normally, the examination is done through a microscope. All right. Okay, this is to show you the normal cell, CIN1 and CIN2 and CIN3, but this is, we can skip this. So for cervical cytology and histological term, ASCA stands for atypical squamous cell or undetermined significance. HCH is atypical squamous cell that cannot exclude hyperplasia, high risk, or low-grade squamous intraepithelial lesion, or high-grade squamous intraepithelial lesion. AIS stands for adenocarcinoma in situ. AGC stands for atypical glandular cell. Then you have a histology, CIN1, CIN2, and CIN3. So when you talk about Bethesda, then it is, we talk about the cytology. Then you talk about Rushat, you talk about the histology. So pap smear, normally the screening is free or with minimal fees. You can go to Klinik Kesihatan. Sometimes the SOCSO or NGO does subsidize. Reason why people are not doing, personal reason, logistic, financial problem. Maybe they are shy. Maybe it costs pain. All right. This is the report from the fact sheet cancer from the Malaysia 2018. It should only show that only 22% of ladies only participate between in the cervical screening age between 20 to 65. All right. Treatment for vaginal cancer, prevention is better than cure. HPV vaccine, cervical screening. A lot of people are actually engaged in co-test. That means doing the HPV screening with a pap smear together. All right. This is we will do a leads for the cervical lesion. This is called LLETZ, where you remove the abnormal CIN cell and tissue. Rarely they require operation, chemotherapy, and radiotherapy. Treatment, surveillance, vaccination, colposcopy, hysterectomy before they turn into cancer, and were times if they are already cervical cancer, chemotherapy, and radiotherapy. So age group to be screened, normally 25 years old and above. 25 to 29 years old, you do a cervical cytology once every 3 years. Why don't do HPV? Because young patients, they're able to eradicate the HPV virus themselves. 30 to 69 years old, you can do a HPV alone, or you can do a co-test, all right, every 3 to 5 years. You can discharge them if they're 3 consecutive negative cytology, if they're above 69 years old, or they have 2 consecutive HPV tests last 10 years, or if they have a negative co-test for the last 10 years. All right, if there's CIN1, CIN2, CIN3, and AIS, then you should continue follow-up for the next 20 years. Women who have never had sexual intercourse before, women who have never had sexual intercourse before, who don't need to engage in the screening. All right, this is according to 2019 guideline. Co-test you can repeat 3 to 5 years. Refer if the HPV, refer to gynecologist if the HPV is positive and the smear is abnormal. Refer if the HPV is high risk 16 and 18, even though the pap smear is normal. Number 3, abnormalities, minor abnormalities, no HPV 1690s, you can keep. Most of the time it's atypical squamous cell or undetermined significance. You repeat the co-test in 1 year. If you repeat the test, HPV is positive or the smear is abnormal, then you should refer. So refer if unsure, atypical glandular cell, low or high-grade squamous intraepithelial lesion, carcinoma in situ, and cancer. For vaginal discharge may be a normal physiology occurrence or pathological manifestation. Normal physiological discharge changes with phases of menstrual cycle. The character of the discharge tend to be clear, stretchable, and also clear in consistency during ovulation. Become thicker, white, and slightly yellow during the luteal phase. Normal healthy discharge are clear to yellow-white. All right, they are not itchy, no discomfort, no swelling, no redness, no sign of inflammation. Does not have a strong odor. Especially this vaginal discharge, clear discharge is normally happen in those with high states of estrogen during ovulation, luteal phase, puberty, pregnancy, and sometimes patients on COCP and also HRT. Normal vaginal discharge is found in 10% of patients presented with vaginal discharge. So abnormal discharge, change in color, volume, consistency, and odor may be associated with symptoms such as itch, soreness, dysuria, pelvic pain, intermenstrual bleed, postcoital bleed. And patient tell you, doctor, it's not a normal discharge. Abnormal vaginal discharge is most commonly caused by infection. Most of the time is vaginal vaginosis is the most common and account for about 50% of all infection. Next is a vulvar vaginal candidiasis, account for 20 to 25% of the patient. All right, trichomoniasis 15 to 25%. That means this, if you can guess about this infection, these are the main culprit: vaginal vaginosis, candidiasis, trichomoniasis. All right. Other than that, you have non-infectious, which account for 5 to 10%. They are atopy, allergy, or irritant or inflammatory in nature. Can be due to the tampon, pads, condom, spermicide, toys, sexual preference, pessary, detergent, bubble bath, and etc. etc. Sometimes radiotherapy, brachytherapy, autoimmune, or also some anti-estrogen medication. So this is to tell you that clinical features associated with the 3 common causes of the vaginal discharge. For bacterial vaginosis, most of the time the discharge is thin, bubbly, fishy in odor. There's no discomfort or itch, no inflammation over at the outside genitalia, and the pH is more than 4.5. If you can do a pH study in your clinic, that will be good. All right. So if the pH is more than 4.5, it can be either vaginal bacterial vaginosis or trichomoniasis. All right. If you do a microscopy, there could be a clue cell. If the patient is sexually active, for the past 3 months, if there's a change in partner in last 2 partner in 6 months, then you should do a STD screening. There's no need to do a retesting because some of them is a common cell. So you do not need to treat the partner. If you trichomoniasis, most of the time the discharge is scanty, profuse, proteic, maybe green or yellow in nature. They are most of the time offensive. There's an itch in vulva, dyspareunia, discomfort. They cause vaginitis and also vulvinitis. There's also something called strawberry cervix, where there's a discomations on the cervix. Then they call strawberry cervix. I show you the picture later. All right. Then in a microscopy, you can see a motile trichomonad. All right. If there's a trichomoniasis, you need to screen for HIV and also STDs. So vulvar vaginitis there's a thick, whitey, curdy discharge. Most of the time is itchy, and there's also inflammation. You also look for fissure satellite lesions, and the pH is less than 4.5. All right. If you don't have microscopy, no problem. If there's no lab service, no problem. You just do a pH, vaginal pH. All right. So atrophic vaginitis is due to many estrogen deficiency in a menopausal patient. There's a clear discharge, vaginal dryness, dyspareunia, and when you examine them, you look at the vagina, it looks like the wall is thin and somewhat friable and also red. All right. So irritants and allergic vaginitis, there's a contact irritants, and also there's a burning sensation, soreness, and the vulvar erythema. Inflammatory, most of the time is autoimmune, can be associated with low estrogen level. All right, sometimes they do have some discharge, dyspareunia. Also, when you examine them, there's a vaginal atrophy. So bacterial vaginosis is an anaerobic bacteria, Ganirella vaginosis, Mobilucum, and also this is also polymicrobial infection. The gram is variable. Normally, you can actually do a MCell diagnostic criteria. Most of the time, the discharge is thin, homogeneous. All right, you can there's a positive whiff test when you put the potassium hydrochloride 10%. There's a amine smell like a urine. All right, there's a clue cell on the microscopy, and then there's a vaginal pH more than 4.5. Right, sometimes what I do is I do a pap smear instead. I can know that whether the cervix is normal. Sometimes pap smear do tell me there's a shift of flora, which is suggestive of bacterial vaginosis. And this bacterial vaginosis, there's an increased risk of PPROM, also preterm labor. Clue cell is actually a cell that on the epithelium covered and here by the gram-negative rods. So treatment, metronidazole 400 mg BD for 7 days, intravaginal gel, clindamycin, metronidazole gel, alternative clindamycin oral. If it's recurred, you can use the same regime, or you can use the metronidazole cream or gel, 0.75% twice per week for 4 to 6 months. So vulvar vaginal candidiasis, most of the time the discharge is cheesy, curdy, flocculent discharge. There's an itch in over the vulva, leg or adult. If you put potassium hydroxide preparation, you can see budding and also pseudo hyphae. This is the budding on the Candida species. All right, this is the hyphae. Sometimes they do cause vulvar vaginal candidiasis. All right, the pH is less than 4.5, which is acidic. We can also do culture. Pap smear do tell me that there's a vulvar vaginal candidiasis. All right, so most of the time, candidiasis, you can treat them with fluconazole 100 mg. If it's severe, you can give 3 doses every 3 days. Day 1, day 4, day 7. You can give topical cotrimazole, miconazole, and etc. If it's recurrent, you can give fluconazole 150 mg daily, 7 to 14 days. Then weekly for 6 months. Then this has been sure to relieve the patient for almost 1 year. If they don't respond, do a culture. It can be non-albicans species, which is less responsive to fluconazole. Non-albicans first-line therapy is either most of the time it's non-fluconazole agent. It can be imidazole, iconazole, cotrimazole, miconazole, and etc. They are effective in eradicating the non-albican candidiasis. All right. Most of the time, if pregnant, you can only use topical because they can cause miscarriage and also malformation. There's no clear evidence of probiotic in in the case of vaginal candidiasis. Trichomoniasis, most of the time is due to STD. You can do in a wet mount microscopy. You can see a protozoa. Gold standard is still PCR. All right, you can do a pap smear. There's an increased risk of STD and HIV. You need to treat the partner. They can cause preterm labor. You can treat them with a single dose of metronidazole. All right, you need to retest them whether the patient is fully treated, normally after 28 days. Non-infectious, you treat the underlying cause, avoid the provoking factors. If it's atrophic vaginitis, you can give them HRT. You can give them Primarin cream, and also wait. Also, you can also give lubrication with a hyaluronic acid there, which increase the water content inside the vagina. Okay, so they reduce the dyspareunia. Other than inflammatory wise, for example, the VAWA, there's an increased pruritus VAWA. You can use steroid and also clindamycin cream. I think that's it for my presentation.
Thank you very much. I myself have never done obstetric or gynecologist as a doctor. It's something that I'm really scared of. I do not know how to even feel the odds. So I really think that yes, this is a really overview and we get the whole picture of all the common diseases. So we will start with some question. I think Mushana Safa asked, Dr. Tan, ovarian drilling is rarely required, but when is it required? And when after other options have failed, can it be done earlier?
When the patient not responding to gonadotropin, that means the hormone FSH, LH through the IVF injection, or they have a very strong hyperandrogenism, then you may require to do ovarian drilling. We'll do ovarian drilling, so you actually destroy the theca cell inside the ovary, the ovary. So this theca cell actually produce androgen. So you also reduce the number of pool of eggs inside the ovary. They, for the last 20 years, for the past 20 years, they do veg recession, meaning cut off quarter of the ovary. All right, so they reduce the egg pool inside the ovary, so the ovary can be normal in number. All right, okay. Sometimes if the ovarian drilling you overdo, you put many holes. So sometimes patient can actually go into diminished ovarian reserve. So because most of the eggs have been destroyed by your laparoscopy ovarian drilling.
Okay, I have a question from Facebook. Amy asked, she was on metformin for PCOS and after 8 years managed to get pregnant induced by Clomid. Okay. After giving birth, her period has been very regular, but the cycle is getting longer. From 30 days now, it went up to 36 days and weight is also increasing. Should she consider to take metformin again?
Yes, you should have engaged back in the general management, weight loss, exercise, then metformin to increase the insulin sensitivity. All right. Then when in that case, patient may have a spontaneous ovulation, even without any medication. All right. If without spontaneous ovulation, if patient is still not pregnant, maybe she can tie some clomiphene. All right. If the clomiphene or Femara fail, then she can just move on with the gonadotropin. That means menopause, those medications to stimulate the ovary to produce more eggs.
Okay, I've shared the QR code. So for the QR code to work, you must be watching on a laptop and scanning it with your handphone. If you're watching it from the handphone, it will not be useful. But if you can't scan the QR code, then please message me on WhatsApp. I will give you my number and we will do it manually for you. So you will need to send me your name, your MMC, and your IC number, and your email address. We go on to the next question. Ku Yusuf asks, in DUB, for DUB in GP practice, I use hormonal treatment, Primolet. How many cycles do we need to give patients?
How many what?
How many cycles?
All right, if they respond well, then will be good. From 5 milligram to 10 milligram. Normally you can give every 3 weeks, then you stop 1 week, cyclical. All right. Actually the best one is still Mirena. You can put it under ultrasound, or you can even start the COCP. Okay. If after COCP or Nocular, if the period is still heavy, then you can add in some tranexamic acid. All right. Okay. If you do a pap smear, you should do an ultrasound. All right. If the pap smear is normal, ultrasound was normal, then it's okay. If they're above 40 years old, then it's better to take the PPL sampling, endometrial biopsy, the catheter that I show you, just to take some sample, just make sure it's not endometrial CA. Okay. Then you can do whatever you want. You want to give Nocular, you want to give COCP. All right, that's fine. All right.
Okay. Another question is Haiza asked, how thick is the endometrial thickness for us to be alarmed? Previously, it was 1.1. Does that still apply?
If it's more than 20, it depends on the age. If it's menopause, it should be less than 5 mm. All right. If it's a pre-menopause, it can be up to 20 mm. There's no problem. All right. Okay. However, if the patient already has risk factors such as polycystic ovarian syndrome, obesity, history of cancer, on tamoxifen, and so on and so forth, if the period is heavy, the endometrium is thick, even 20 will be alarming. This kind of cases is better to do an office PPL sampling, then you can manage accordingly. If the PPL is normal, then you can start COCP.
Okay. I think we have Haiza also asked, in teenagers with menarche is less than 2 years and complain of irregular bleeding, is it necessary to do any ultrasound pelvic?
Most of the time, if the period not regular, right, is due to the hypothalamus pituitary ovarian axis, which is not matured. Most of the time, the pelvic scan will be normal. All right. However, unless you are suspicion when you examine the tummy, there's a mass. All right. Then you probably want to do a scan. All right. Or they complain of painful period, or they complain of something else, then it's better to engage with the ultrasound scan. Actually, initially I want to talk about ultrasound in gynecology, but I already over time. So I will actually select few clips from the YouTube we are share with you, which I think may be helpful in the general practice. All right. Later our admin will share the link. Then you can actually watch the video. Then how to scan the uterus, how to scan the ovary, how to scan the endometrium lining. Okay.
I think, yeah, I can also share the link on our group chat. So if you are not with us on the group chat, please join our Telegram group chat. We can share it there. If Ashini asks if routine PAPs are very fruitful, if routine pap smear for 30 plus shows inflammation, how do we treat?
All right, as long as there's no dysplasia, CIN1 or CIN2 or CIN3 or glandular atypical glandular cell, then you either can take a swab or can give you can try a antibiotic. All right. If it's just inflammation, sometimes they'll tell you indicate of repair, indicate of this healing, then you don't be bothered. If you want, you can take a HPV virus subtype. All right. If the HPV is normal, then you just leave it alone.
Okay. Right. I think we will need to stop here. And the reason is also because I have to rush into the hospital. I'm so sorry. So thank you very much, Tan. I think it's been a very interesting talk, very, what? a lot of pictures to illustrate. Okay, so easy for people like me to understand. But I want to ask you last question. The morcellation.
I talked too many topics.
Sorry. Morcellation. Do you believe in
Morcellation, yes.
morcellation?
You talk about.
Do you believe in morcellation?
All right. Okay, this morcellation they banned morcellation because there's one case in US where
Yes.
they morcellate the fibroid, and it was found to have this sarcoma. So it actually, when they morcellate some of the tissue, they spread into other parts of the peritoneum. All right, they claim they worsen the condition. Whether or not this patient have a poor prognosis, when you talk about sarcoma, all right, okay. Also recommended to morcellate inside the bag. Also morcellate if the fibroid less, you only can morcellate if the fibroid less than 5 cm.
Okay, the reason I ask is because I had sarcoma. It
Okay.
was misdiagnosed as fibroid, and when 2 years down the road, it was actually found on my small bowel, attached to a lot of the omentum.
Right.
Yeah. So I had.
So there's another way of avoid morcellation is you can do a colpotomy. That means cut the part of the vagina from the laparoscopy and take out from the vagina outlet. All right. Or you can put inside the bag, morcellate inside the bag. All right. If it's more than 5 cm, we prefer not to morcellate. It's better to do a laparotomy to take out the fibroid.
Okay, thank you very much.
Thank you. Thank you.
I see you guys. Next week, we have another webinar. I think it's on genetic counseling. I will share the details later. You can register. And happy Malaysia Day and happy holiday tomorrow. Okay, bye.
Thank you, everyone. Thank you.
Thank you. Thank you so much, Tan.